All right, I think I will get started. I think I know everybody in here, but if you don't know me, I'm Katie, and in 2 weeks I will actually be a PGY4 here in the department. For those of you who just came, this is not the color on my screen, so some of these slides might be a little bit hard to see some of the pictures, but just bear with me. It looks like everyone enjoying from that site will see it normally, and then everybody from here won't. But we'll make it through. So I wanted to talk about trauma resuscitation before I get started. Just a few people to thank. Even from over in New Zealand, Dr. Bishop did help me with this talk, with some of the resources, as well as going through the slides. I also was in touch with Dr. Naherniak with transfusion medicine, who gave me some advice and permission to use some of her slides from her recent half-day talk for us, as well as Dr. Arabes Parker. She's currently my ICU fellow right now and is a certified hematologist, so she was a big help as well. So objectives might look really basic here, but want to dive into a lot of details around this. Talk a little bit about hemorrhagic shock and just its clinical relevance as it is here, especially at the U of A. Dive a little bit more into the coagulopathies and trauma, and how we should and could manage these now and the future directions of this. Talk about the fluid and blood components that we use in trauma resuscitation, and again the protocol around using these, which leads into the massive hemorrhage protocol. And I think that's sort of the new terminology they're wanting us to use, is the MHP versus the massive transfusion protocol. So the two leading causes of trauma are neurological injury and blood loss. Any uncontrolled bleeding can contribute up to 40% of trauma-related deaths globally. More times than not, severe trauma will result in trauma-induced coagulopathy, and this can increase mortality up to 4-fold. And it's been shown to correlate with severity of hemorrhagic shock, which seems obvious, but also the number of red cells transfused. So although blood transfusion can be life-saving, the transfusion and other blood components is associated with adverse outcomes, and there's always risks when you're giving these products. So hemorrhagic shock, we all know the classes of shock, so just sort of focusing on this one. All of them, maybe especially hemorrhagic shock, depending, is a dynamic process and can rapidly progress, which just leads to the importance of constantly reassessing the patient's status, the volume status, when these patients come in. And this triggers changes throughout the body. So it can lead to compensation with increased heart rate, contractility, selective vasoconstriction. It leads to redistribution of blood flow away from the non-vital organs of the skin and the gut, the GI tract, kidneys, etc. And then you also get hormonal changes that cause the kidneys to retain sodium and water and help to support that intravascular volume. So our body initially does that, and this is how, essentially to preserve our cardiac output and our blood pressure. Then it's just sort of this whole series of events that happen. So a patient is persistently hypoperfused due to hemorrhagic shock. This results in anaerobic metabolism, and we get metabolic acidosis. This change in metabolic activity results in decreased heat production. We get hypothermia. And then this synergistically causes all the impairment of hemostasis and our trauma-induced coagulopathy. And this, as we all know, is referred to as the lethal triad. So acidosis, hypothermia, and coagulopathy. So acidosis, typically problems with secondary hemostasis. So this is your coagulation factor activation. Hypothermia, you think more about problems with platelet function, so adhesion and aggregation. And then you obviously get other things like reduced metabolic activity of tissues, resulting in decreased heat production. And then when you think about hypothermia, yes, this affects the platelets, but also other things can affect it. So the temperature in our rooms, the ORs, the temperature in the emerge, the temperature of the fluids we're giving, just lots of things to think about with hypothermia. And then coagulopathy. So you get hyperfibrinolysis, there's coagulation activation, and then there's consumption coagulopathy, and that's essentially DIC. There's kind of two forms of DIC. You sort of have this thrombotic form of DIC, so you might have someone who's septic and producing thrombus. They may have ischemic digits. It's more of a thrombotic form of DIC, but in trauma, we get this coagulopathic sort of element of DIC, which is those three things. So the classification, don't need to go through all the classes necessarily. Just putting this up, this was sort of developed by ATLS to classify hemorrhagic shock based on the percentage of blood volume loss, but it just distinguishes between the various classes and shows that it can be really difficult. In some people you might find preservation of blood pressure up until class 4 or heart rate, etc. So it's hard to sort of decide where they are on the shock based on some of their vitals, and then you may not also be able to estimate the amount of blood volume loss. So essentially you sort of think about when the blood loss is approached about half the circulating volume, that's when we start to see the relationship between the cardiac output and the blood pressure. So a brief review of hemostasis. There's 3 phases. The third one there is called coagulation, but really it should be secondary hemostasis. So the first one is vascular injury. There's some sort of damage to the endothelial vascular wall, endothelial, the collagen and tissue factor are essentially activated. In this stage, you've got an injury, you're bleeding, you need blood. Okay, so that's when you're giving your red cells. For primary hemostasis, this is your platelet plug. So there's an interaction with von Willebrand factors. So here, you're giving platelets, you're giving cryo, because it has some von Willebrand or just von Willebrand concentrate, potentially even desmopressin. And then the third phase of hemostasis is secondary hemostasis. And this is the formation of the fibrin clot. So everything you need to do that, all your coagulation factors, your fibrinogen. So again, that's what you're replacing. You're replacing replacing with frozen plasma, cryo, fibrinogen, etc. And of course, the fourth phase is fibrinolysis, but that's kind of what we're trying to avoid here. Sorry, one sec. So coagulopathy in trauma results from a lot of things. The derangements we just talked about, so acidosis, hypothermia, but you can also get hemodilution related to fluid or blood administration. It's important to know that critical bleeding is appreciated when coagulation factors fall below 25% expected. So you need quite a bit of hemodilution to really start seeing this. It's certainly a contributor, but it's not ever going to be your main one unless they've just been flogged with, 20 liters before you see them. And also generally appreciated with blood volume replaced by 8 to 10 units in an adult. And then platelets are reduced by 50% with 10 units of red blood cells. So just numbers to keep in mind if a patient has been down, say in emerge and have been given blood, nothing else, and you initiate the massive hemorrhage protocol for which they send up 6 units of red cells, maybe 4 units of plasma, you're going to be way behind on your plasma. So it's always important to know what they've got maybe in transport, in emerge, and what you might potentially be dealing with as far as your coagulation status when we see them, not necessarily when they arrive at their sort of peripheral hospital or here in emerge. They've also, when I was reading about this, described this acute traumatic coagulopathy. So this apparently occurs in severely injured patients, and it's independent of and in addition to the above factors. And it's described as a dysregulation of the protein C system. It seems a little bit controversial. I read a few papers about this, and some aren't so sure that this is a thing, but I think nonetheless, there's probably more going on than we can predict or totally account for. And potentially that this is also a contributor to this, and increases with hypotension, injury severity scores, head injury, worsening base deficit. And then again, as I mentioned earlier, DIC, and DIC of the fibrinolytic component. So hyperfibrinolysis, coagulation activation, and consumptive coagulopathy. So not a thrombotic type of DIC in this case. This is not at all to go through the coagulation cascade. I know that this is almost even outdated now. This represents in vitro data, not in vivo, which is what we're dealing with. But I think important to talk about, you know, when we get a PTINR, we're talking about the extrinsic and the common pathway, the PTT, intrinsic and comic pathway, but you may or may not notice that they've taken PTT completely off trauma labs because it's not a useful test at all. It really doesn't tell you anything. These tests were designed initially for people on anticoagulation to monitor their anticoagulation, by no means to kind of run a trauma. So they fail to present in vivo, like I said. They don't detect platelet dysfunction, assess clot strength or clot lysis. These tests, you take a sample from your patient who might be hypothermic. They do the test at 37 degrees, so it's not even indicative of what is happening in your patient. But if this is what you have, if all you have is laboratory tests like this, then it's not unreasonable to do serial measurements and then follow your patient clinically, and then you can guide sort of decision making and fluid replacement based off that. So it was a little difficult to find some of the laboratory recommendations. That's why I talked to Dr. Herniak and then Dr. Parker about this. But the biggest thing, and a lot of these things may be done, but just to not forget about some of the basic, or not basic, but to trauma labs, like a cross match is huge. If you think you're going to be giving blood, the faster that they can get a type and screen cross match, the faster you can get appropriate product for your patient, and then subsequently less wastage of sort of resources that we have very little of occurs. So PTT, I should have taken that out actually, because I just said they don't do it anymore. Fibrinogen, and then of course your electrolytes, ABGs if you can get one, so you have a lactate and an ionized calcium. Maintaining your platelets above 50, this is sort of, there's a range. Certainly if someone has a brain injury, you would aim, or a spinal cord injury, something like that, you would aim for platelets higher than that, but I think 50 is a reasonable goal. Fibrinogen greater than 1, again, you know, you have to look at the clinical status of your patient. If your fibrinogen is 1 and you're no bleeding, then there's no point in going too much higher at that time, or you might be up at 1.5, 1.7, and you're just not getting any reprieve. If this patient was pregnant and this was an obstetrical hemorrhage, you would aim for a higher fibrinogen. In fact, in those patients, a fibrinogen of 2, you would be concerned. That would be very low, very abnormal. CV surgery, I think aim for a higher fibrinogen as well. And then just like I said before, frequently assessing your coagulation parameters. So typically every 30 minutes, sending off your blue coag to just assess hemostasis and resolution of coagulopathy, and to certainly not forget when you're giving products to measure electrolytes, specifically calcium and potassium. So this leads into ROTEM and TAG. I'll sort of focus more on ROTEM because that's what we have up here. But this is a viscoelastic method of testing coagulation that is real time and really represents in vivo status of the patient. So it allows for rapid assessment in critical bleeding situations, and provides a lot more information than we're getting off our standard lab tests. So clot dynamics, development, stabilization, and dissolution. There's been a lot of reviews. This one Cochrane review didn't show a survival benefit. However, there was reduced bleeding in the use of FFP platelets when TAG and ROTEM were used when weight down. This recent randomized control trial from the Annals of Surgery in 2016 actually did show a survival benefit. It is a single center study, but they did show a significantly higher survival in the sort of people that follow these assays versus the ones that didn't. So let's see, they said that similar number of red cells, but more plasma and platelets were used in the first 2 hours of resuscitation. They found platelets fibrinogen were given earlier with goal-directed hemostatic resuscitation, and essentially likely the survival benefit comes from giving these products earlier, giving the right product at the right time to the right patient. So this was a really interesting paper, if you guys want to read it, just that this TEG-guided MTP to resuscitate severely injured patients really does improve survival compared to that not guided by TEG or ROTEM. So ROTEM, how does it work? Basically, we take a whole blood sample, place it in this plastic cup with a pipette. It's then recalcified with calcium chloride and activated with a reagent. So it depends on what you're trying to measure, but they can give this XTEM reagent, which is like tissue factor, an INTEM reagent, et cetera, HepTem, like a heparinase and a protein, and all these things to sort of give you different types of information about what's going on in your patient. And then the pin is lowered into the cup and it's rotated. It's sort of at a slight angle, about a 5-degree angle. And essentially, as the clot forms, there's more torque on the pin, and as the clot dissolutes, the torque is less. And this is detected optically. So there's a light detector, and it goes through this fancy data processor and gives you this graph that might seem somewhat confusing, but I think we'll go through a few examples. But essentially you're measuring up front here is the clotting time. So clotting time is just from the start to the initiation of the clot formation time, the time to form an actual clot. They talk about this alpha angle. It's sort of related to the clot formation time, your maximum clot firmness, and then your maximum lysis of the clot. So let's try an example here. So this is an example of a non-coagulopathic patient. So over here, this is the XTEM. So this is similar to PT. This uses tissue factor as an activator and provides information similar to your INR. The INTEM is similar to the PTT, and it uses some other agents that I can barely pronounce as activators, and this is your intrinsic pathway. I did mention that PTT isn't super important, but when you do a HepTem test to decide if heparin is affecting your outcome, this is the one you compare it to. So it does have some value here. So the HepTem, which isn't on here, it excludes the effects of heparin. So it's essentially the same test as that, but it uncovers any coagulopathy which might coexist alongside heparinization. So if you do the HepTem and then all of a sudden you see your clotting time shorten, then you know that that was all a heparin induced change on the ROTEM. And that's good for people who are doing CV that may have given a lot of heparin and they want to see what their patient is going to look like after they reverse the protamine and what their coagulopathy might be afterwards. With FibTem, this isolates the fibrinogen function, uses a platelet inhibitor, and blocks the platelet contribution to the clot formation. So you can see even in a non-coagulopathic person, this does not get very big, but then they have sort of parameters at which this is abnormal. And then lastly, the APTEM excludes fibrinolysis. So it uses aprotein to inhibit the fibrinolytic proteins, and this one's otherwise identical to the XTEM. And then they also have one that you can run to help with oral anticoagulants. So this is a thrombocytopenic or a patient with thrombocytopenia or poor platelet function. It doesn't show up super well. But you can see that the clot formation time is prolonged. So this patient either has low platelets or poor platelet function, and maybe even some contribution from low fibrinogen. You also see that the maximal clot firmness is much shorter, and there's a whole list of reference numbers that you can do that. And so that might also represent poor clot stability, again, low platelets, poor platelet function. So this is quite nicely shows you that you're having an issue with your platelets and can guide your replacement there. This one is low fibrinogen. So again, you've got a prolonged clot formation time because fibrinogen is involved here. And then you can see on your fib-tem graph that it doesn't reach the amplitude that it should. It's much less than 9 millimeters, I think, it shows that you've got a problem with fibrinogen. So again, here you look at these graphs, you know that you need more fibrinogen. This is the hep-tem I was talking about. So if you look here, without the heparinase, you see you have a really long clotting time. But then when you add in the hep-tem, you see that that's shortened. So we know that this is all from heparin, and we can sort of decide, if you're concerned, how much is on board or what this patient's going to look like after. This is a really good one to look at. And then lastly, this is hyperfibrinolysis. So the standard feature here is the rapid decrease in the amplitude in all the tests except for the APTEM to 0. So this is, again, the one where aprotein is added. So the point really is just to show how useful this is. You run a test and you get all these really nice evaluations of not just numbers, but function and strength and whatnot. And obviously other people know it a little bit more in depth than that. So resuscitation fluid. Essentially, the ideal resuscitation fluid doesn't exist. If you're hemorrhaging, you need blood, but in the interim, you should probably be giving something. And from what I could find, and from what I've heard, that should be crystalloid. So you don't want to flog them again with crystalloid, but as a temporizing agent, a balanced salt solution is your best bet. There is no advantage of colloid. A lot of these studies, like the SAFE study, the HES studying hydroxyethyl starch, showed no benefit to the colloids for the most part. And I mean, these tests were done in critically ill patients in the ICU. But you could extrapolate that someone coming in with hemorrhagic shock and severe trauma might be heading there afterwards, that they increase the rate of renal replacement therapy after their use. So really be careful with your crystalloids, so not too much normal saline, because we all know you get hyperchloremic metabolic acidosis and can develop AKI. There's some studies out there now starting to look at hypertonic saline. It's early use in resuscitation, but it hasn't so far improved short or long-term outcomes. So really, as I mentioned, a balanced salt solution has been increasingly recommended as your first line fluid. So we know we're giving fluid, we're giving some crystalloid, but how much? Really, again, is this aggressive or low volume resuscitation? We sort of all know the 3-to-1 rule, where you replete 3 mils of crystalloid for every estimated 1 mil of blood loss, with the aim of restoring a normal blood pressure. But this is quite outdated now, because people were getting so much fluid. It can exacerbate bleeding from injured vessels. It can worsen our coagulopathy due to dilution effect, and potentially even increase other adverse effects such as tissue edema, abdominal compartment syndrome, and acute lung injury. So we have to be careful with our fluids, and I think the 3-to-1 rule is pretty much gone, and we're adopting more of this hypotensive resuscitation. Again, this doesn't apply to all of our trauma patients. If someone has a traumatic brain injury, another CNS injury, you might be having to give a little bit more in order to maintain that systolic or mean arterial pressure at a higher level. But essentially the point is that you need to minimize your use of crystalloids and increase the use of blood products. So recognizing what type of shock, hemorrhagic shock, get your patient's type and screen cross-matched, give crystalloid for temporization, and then get the products that you need. In addition to all of that, increased crystalloids can worsen the lethal triad. So hemodilution, and especially in the periphery or in emerge, these are unwarmed fluids, so patients are becoming more hypothermic. So red cells are pretty obvious. That's what we should be giving, preferably ABO and RH group compatibility, but patients can receive uncross-matched blood cells, so group O RH negative cells or group O RH positive cells. You have to be careful giving them to younger women. So RH D negative cells can safely be given to D positive recipients, but transfusion of D positive cells to a D negative recipient can result in a formation of anti-D antibody, and that's about 20%. So 1 in 5 will develop that. And then they can have potentially have consequences such as hemolytic disease of the newborn in a future pregnancy. So if you can, you try to save those ones for females under 45 of childbearing age. But at the end of the day, if you have to give, positive to save a life, then that's what you do. Other components are frozen plasma. So we don't have fresh frozen plasma here. We have frozen plasma. That was like something that was driven home to me to tell everybody. And this contains all coagulation factors normally present in plasma. It takes 20 to 30 minutes to thaw. They have no thawed plasma available here, so you need to call early. And as I was mentioning earlier, if you know your patient has gotten a lot of red cells in emerge, and you need to call early for more frozen plasma as well, not just because what you're going to get in your massive hemorrhage protocol kit will not be enough. Here, the AB is the universal donor, so opposite to red cells. You don't need to RH match, but important to note that less than 4% of donors are AB. So this is a tricky product to give out and can run out really quickly. So that's why we really need to try to cross-match as quickly as we can. Platelets, very, very short supply. You will rarely actually see these put in the kit. They have a short shelf life. They're only 5 days, and I think they only have 7 units of whatnot. Some of the hospitals only have 1 or 2. So if you get to the point where you're using lots of platelets, then transfusion is really trying to juggle around who gets them. Maybe the pediatric patient with leukemia doesn't get platelets tomorrow because you're using them, etc. You have to be really careful with the platelets, or they are very stingy on the platelets. And then there's cryoprecipitate. So this contains not just fibrinogen, but other factors as well. Factor 8, 13, von Willebrand factor, fibronectin, and a few platelet particles. This is also stored frozen. It's super annoying, as we all know, to draw up and give to the patient. It's 1 bag per 10 kilograms. So if your patient's 80 kilograms, they'll send you 8 bags. Typically, they don't know the weight, so they just send 10. But that's sort of how it works. The nice thing about fibrinogen now is they have fibrinogen concentrate. There's no ongoing trial, or the results of ongoing trials aren't known yet. So the National Advisory Committee can't necessarily recommend FC over cryo or FP, but you will notice that you'll get this sometimes in the OR, or they'll send it down to emerge. It's so much better to just reconstitute it and give it. Obviously, without in the fibrinogen concentrate, you're not getting all the other factors that I mentioned. But initially, if you have a low fibrinogen, it might be still beneficial to give this, and then you can always give cryo later on. And so then tranexamic acid. This is something we should be thinking of right off the bat. This is an antifibrinolytic therapy. It completely inhibits the activation of plasminogen. There's been a few studies, specifically the CRASH-2 study showed the mortality benefit in trauma patients. Now, some of these were people who were potential, I don't know how to say it, like potential traumas, like they hadn't sort of progressed to a bad state of hemorrhagic shock yet or anything like that. So it's a little bit swayed, but I mean, it's a randomized control study with more than 20,000 patients where they found that if you gave the tranexamic acid within 3 hours of injury, it did reduce mortality. Talking to the hematologist, she feels even if you're outside of that 3-hour window, your patient is still bleeding clinically, you're not getting as far as you'd like, she would recommend still giving tranexamic acid, even though this study only recommends it really if it's under 3 hours. There's the CRASH-3 study that's not finished yet, but they're testing the benefit of TXA in head injury as well. So something to think about. And then monitoring your response. This is sort of just another reminder slide, just regular assessments, both clinically and lab assessments, and try to think of some minimum target goals. So systolic 80 to 100, MAP 60, again, you might need a higher threshold in the CNS or spinal trauma, heart rate less than 100, a urine output, temperature, you're aiming for normothermia, try to get them above 35 if you're struggling, but don't forget about other ways you can do this. A warmer air hugger, warming blanket underneath the patient, warm your OR, warm your fluids, and then other things that we might not think of right away, but like measuring a CVP. I know that that's a little controversial, but your mixed venous O2 is a big one, and of course ABG to check your lactate, your base excess, and your ionized calcium. So massive transfusion. I actually think they should put these in all the kits. Like it just says consider tranexamic acid. That was my suggestion to the hematologist. This is defined, well, there's a million definitions, but as an infusion within 24-hour period of a volume of blood approximating the recipient's total blood volume. Other definitions, 5 units in 4 hours, 50% volume loss in 3 hours, transfusion of more than 10 units of cells in an adult, and actually in some ways that's sort of more the one we go by, or patients requiring 4 units of blood within 1 hour with the anticipation of ongoing blood loss. And the massive hemorrhage protocol is sort of these 6 T's. So triggering, talking, testing, TXA, transfusion, temperature, and then not forgetting to terminate the MTP. And that was something that was sort of brought up to us in our half day as well, is like, you know, we get going with all this and then no one calls them back to say, hey, we're done. And there's an ABC score for this, so assessment of blood consumption, trauma score, to help you decide if you're unsure that you may potentially be going down this or initiating this massive hemorrhage protocol. And basically a score of greater than or equal to 2 has 55% positive predictive value, 5% negative predictive value of the fact that you're going to need to do this. So penetrating mechanism, positive fast test, arrival systolic less than 90, or arrival heart rate greater than 120. So the other controversy now is this 1-to-1-to-1. Should we be doing it? Is it recommended? Is it beneficial? And I can talk a little bit more about that on the next couple slides. But as we know, there are constraints to this. We need time to thaw the products. As you mentioned, frozen plasma takes 20-25 minutes to thaw. The availability, the feasibility, if your patient is not cross-matched and you're giving out AB frozen plasma, you may run out of that faster than you think. As I mentioned, platelets are in really short supply. So you have O-neg red cells, AB plasma, and then all platelets. And then just, you know, wanting to avoid unnecessary exposure to blood components is always a big thing we need to think about. So there's been several studies, and there's also a recent systematic review of these 2 papers included that compared the effect of this fixed ratio 1-1-1 transfusion protocol versus, in this case, laboratory results guided transfusion, and in this case, the 1-to-1-to-2, the proper trial. This first guy was a single center unblinded randomized control trial. It had 2 arm parallel group design. And as I mentioned, it compared 1-to-1-to-1 versus an institutional usual protocol that targeted hemoglobin greater than 70, INR less than 1.8, and platelets greater than 50. Their primary outcome was feasibility. And then they also measured the safety in terms of 28-day all-cause mortality. Essentially, they found that it was feasible. I believe this center actually had thawed plasma, which made it more feasible for them, but the wastage was quite a bit higher in the fixed ratio group, so certainly something to think about. In the proper trial, the objective was to determine the effectiveness and safety of transfusing patients with a severe trauma using 1-to-1-to-1 compared to 1-to-1-to-2, and this was a multi-site randomized control trial, and essentially there was no difference in 24 and 30-day mortality. However, the author at the end still recommends 1-to-1-to-1 despite this, but you know, at the end of the day, if there is no multi-organ failure or mortality benefit and we're chronically short of these products, I think as the limited resource really needs to be restricted to patients where there's actually a proven benefit. And this is sort of the review of all those papers where they combine 6 randomized control trials. And they again found overall low quality evidence for any sort of difference in mortality and moderate or quality evidence for difference of morbidity between the 1-to-1 and the 1-to-1-to-2 in adult patients with severe trauma. So there really was not sufficient evidence to recommend 1-to-1-to-1. And this slide, some of the papers will say to, you know, if you're following the INR, to try to keep it less than 1.8. I thought this was kind of an interesting graph. It shows this nonlinear relationship between the levels of coagulation factors and the clotting test results. And in this case, the INR, decrease in clotting factors up to about 30% of normal start prolonging the clotting test times, but still support, so looking at this side of the graph, but still support normal hemostasis. So if you treat an adult or child over here with frozen plasma to raise the level of their coagulation factors to point B, it has quite a marked effect on their INR, whereas over here you can see you treat this adult or child with the same amount of frozen plasma and you're really not getting very much. So there is a point, and I mentioned earlier 10 units will dilute you down to about 25% of your factors, where you only need 30% to sort of maintain an INR that's going to continue to help with the clotting and coagulation. And then this, we're sort of gearing up to the end here. This was recently published in Anesthesia this year. It's not a randomized control trial or anything, but basically this retrospective observational study, it compared 2 time periods at the University of Zurich. One before and one after they implemented new sort of transfusion management protocols. That included use of goal-directed coagulation management, the use of TEG and ROTEM, whole body CT, things like early use of tranexamic acid, and things like surgery when indicated, et cetera, et cetera. And they found that the mortality at 24 hours and the overall in-hospital mortality was significantly lower in the after group, and that the length of ICU stay and days off of ventilator support also reduced. So these new strategies to sort of direct us in resuscitation are not just, they're life-saving, they're product-saving, so that might be life-saving for another patient. They're more efficient, and they're just more effective. Again, giving the right patient the right product at the right time is really important, and I think we can do that with a lot of the equipment and advances that we have now. So this is from that same paper, just gives you an outline of their goal-directed transfusion and coagulation. Not bad. So, just take home, involve transfusion medicine early. They're really helpful administering the proper products and the appropriate products. Use your adjuncts early, so tranexamic acid, use it right off the hop. Dynamic assessment, so goal-directed transfusion, goal-directed fluid resuscitation and coagulation, so that requires frequent clinical laboratory assessments. ROTEM, if you can use it. Don't follow the 1-to-1-to-1. And then, as I mentioned before, the low volume crystalloid resuscitation. Then replace your losses. And that's it. Thank you.